Ischemia occurs when there is an imbalance between the supply of nutrients from the blood versus the demand of the organ. If we're going to place this in the context of cardiac ischemia, then make sure we understand the difference between hypoxia, which is a decrease in the oxygen supplied, versus ischemia, which is not only a decrease in oxygen, but also a decrease in nutrients. As well, because ischemia implies no blood flow, there is also an inability to clear any of the waste byproducts. So as a general rule, hypoxia is much better tolerated in an organ than ischemia. So when we talk about ischemia in the heart, we really want to talk about this balance between supply and demand. You can sort of think about it as putting it on a teeter-totter, and we can see that the supply is going to be driven by the oxygen content of the blood and then the actual blood flow. And blood flow is going to be proportional to the perfusion pressure and the resistance of the vessel. That's going to bring us to Poiseuille's law to discuss those two. What drives demand in the heart? Well, the parameters that measure demand are going to include wall stress, heart rate, and they're going to be driven by contractility. So every time you think about a patient with angina, because this is going to present as pain, we're always thinking about the supply versus demand. The O2 content, that's pretty straightforward. The only disease that we really think about that's going to involve a drop in O2 content, in practical terms, are going to be our anemias. When your patient's hemoglobin starts dropping below, say, 10 grams per cent, they might start expressing chest pain. When we talk about blood flow, this really is Poiseuille's law. Poiseuille's law states the parameters that account for the flow. So let's let flow stand for Q. And remember that it's going to be proportional to the change in pressure times r to the fourth and decreased with increased viscosity of the fluid and the length of the vessel. The key parameter that we're going to be using, obviously, is r to the fourth, because that's going to be related to atherosclerotic occlusions of the coronary artery. Resistance specifically refers to the r to the fourth of the diameter. When we talk about the demand side, we really have to review our understanding of wall stress, because this comes out of Laplace's law. Laplace's law states that wall stress is proportional to the pressure in the structure times the radius of the chamber divided by the thickness of the wall. In practical terms, the proxies that we use for wall stress are going to be left ventricular end diastolic pressure, or volume. In practical terms, the pressure in the chamber, that's just blood pressure. And then thickness of the wall is the thickness of the left ventricular wall, and radius is the chamber diameter. Heart rate is self-explanatory, so the only other parameter we really need to make sure we have a grasp of is contractility, and contractility really is proportional to our intracellular calcium level. This is going to be highly driven by our autonomic nervous system, increasing with sympathetic input and decreasing with cholinergic input. How does the blood supply get given to the heart? Well, we always want to talk about our blood supply, as we reviewed in our anatomy section, as the subepicardial coronary artery going down through progressively smaller vessels, through small arteries, and then into the arterioles, which are really 1 to 2 millimeter, very small tubules that only have 1 to 2 small muscle layers. We have flow through the epicardial artery, but resistance is at the level of the arteriole. Anytime we need to increase blood flow with demand, we can dilate the arterioles. Regulating demand is not going to be through the level of the epicardial artery, but through the level of the arterioles. Regulation at the level of the small arteries and arterioles, remember there's no actual abrupt distinction between the two, one progressively goes into the other, occurs at a local and a neural level. At the local level, we have our endothelial cells lining the vessel, and then underneath those we have the smooth muscle layers of the wall. And in arterial, there's really only 1 to 2 layers of muscle. The basic control of this then is going to be through local metabolites and through the endothelial cell. The local metabolites are going to be multiple, but a good example of one that can stand for all the others will be adenosine. Metabolites, anytime there's decreased oxygen, more ATP is converted to adenosine, and it goes into the smooth muscles and causes dilation. There's also regulation by the endothelial cells. Endothelial cells can cause dilation through production of multiple substances, but the 2 most important ones are going to be nitric oxide and prostaglandins for dilation and endothelin for constriction. The nitric oxide has a metabolic pathway that we're going to need because it has pharmacologic significance. When we have our smooth muscle cell, the nitric oxide diffuses in after production in the endothelial cell, where it increases cyclase. And cyclase is going to increase the conversion of cyclic GTP into cyclic GMP, and cyclic GMP decreases the intracellular calcium, and that then leads to dilation, lengthening of the muscle. By comparison, prostaglandins dilate through mechanisms that are poorly described. When we talk about the causes of vasoconstriction, there are multiple compounds that are produced to do this, but the one that we let stand for all the others is endothelin. We can see then that there's local control of the resistant structures by local metabolites. Adenosine stands as a good proxy for them all. And then there's profound regulation by the endothelial cell, which has vasodilatory substances of nitric oxide and prostaglandins, amongst others, and then vasoconstriction substances, and let endothelin start for all of those. The other change that we can see is going to be neural. Neural control is going to be at 2 levels. The level of the blood vessels themselves, which are going to be our alpha 1, classically A receptors, which are mediated through the GQ system, and then the demand of the heart itself, which is going to be regulated through our B1 in the adrenergic system and our M2 in our muscarinic system. Let's take these physiologic principles and apply them to ischemia. Well, the first way we're going to get ischemia is the most obvious, and that's when we get vessel narrowing. And in the coronary arteries, this is going to be by atherosclerosis for most of clinical medicine. Poiseuille's law says that flow is proportional to the radius to the 4th power. Therefore, the ability to increase flow by decreasing the resistance in the small artery is going to be restricted if we have a large artery occluded upstream. All the dilation downstream is not going to permit that flow to increase because it's obstructed by a fixed occlusion upstream. Any dilation you get isn't going to help because remember, oxygen extraction by the heart is maximal even at rest. So the only way you can increase demand and increase blood flow to it is for the whole system to dilate from the main artery all the way through to the arterioles. At the coronary artery level, when we have a 70% occlusion, that is the level at which we get a demand ischemia. You're fine at rest, but if you need to increase that blood flow up to 5-fold as it can normally, you can't get it past that fixed occlusion. And anytime you have an occlusion that's going to be greater than 90%, you're going to have ischemia at rest. The second problem we have to face when we're dealing with ischemia is we have to talk about endothelial dysfunction. The endothelial cell has the key roles of regulating tone through vasoconstriction by nitric oxide and prostaglandins, and vasoconstriction through substances such as endothelin. We can regulate locally through our endothelial cell and neurally through our sympathetic alpha-1 receptors in the normal heart. But when we have abnormal endothelial cells, we get a paradoxical response. When we have abnormal endothelial cells and we get our alpha-1 sympathetic stimulation, paradoxically, instead of getting the vasodilation, we get abnormal endothelial secretion, leading to vasoconstriction. The other problem that we have anytime we have endothelial dysfunction is we're also going to have abnormal regulation of thrombosis. One can have a perfectly open artery, but in a setting of abnormal endothelial cells, a sympathetic trigger can cause vasoconstriction, and of course that's a pretty good model for our vasospastic causes of coronary ischemia. The third thing we have to understand in ischemia is, where does the pain come from? And the pain is thought to be due to an increase in the metabolic products. The most important one that we let stand for all the other is going to be adenosine, which increases when you don't have oxygen to recreate ATP. This then stimulates the pain receptors in the local area, but this is now a visceral pain, which means it doesn't localize to the site, it localizes embryologically to where the heart starts from. That localizes to the region of C7 to T4, which is precordial. This can also refer to the jaw and the arm. And then the fourth thing we want to talk about in ischemia is we want to talk about the cellular effects. Obviously, the most dire cellular effect is we get necrosis. But there are two other cellular effects that are just being understood and are evolving as part of our understanding of treatment. When the myocytes suffer acute hypoxia, they can enter what is called a stunned state, which means they stop contracting within seconds, but it is reversible. That's why it's so critical to open up the coronary artery as soon as we can, and is the basis for the clinical aphorism of time is muscle in treatments of occlusion. The second is, if the myocytes suffer chronic ischemia, they can enter a unique state called hibernating, in which they are non-functioning but not dead. The clinical application of this is revascularization of patients who had long-standing ischemia and are not responding to pharmacologic treatments, in the hope that bringing in a new blood supply will unlock and help recover these hibernating myocytes. Let's talk about the two different types of ischemic syndromes. The first we want to talk about are those in which the obstruction comes from a stable plaque. And remember how atherosclerosis starts. Atherosclerosis always starts with endothelial injury. Endothelial injury then allows the insedation of LDL. And that then is going to allow a buildup in the wall of LDL. That LDL oxidizes, and an oxidized LDL is a pathogen-associated molecular pattern, which means it attracts inflammatory cells, in particular macrophages. So now we've established our macrophage signal, and the third step that we're going to see is the presence of inflammation in the sense of monocytes. Monocytes secrete growth factors, and these growth factors are going to stimulate the proliferation of smooth muscles. And now with the proliferation of the smooth muscle, we have the formation of a significant stable plaque. When we talk about what the mature plaque looks like, we really want to talk about three elements that are going to relate to its risk of causing thrombosis. The first risk that we want to understand is the endothelial cells get lost and get replaced by a fibrous capsule. The stable plaque has a thick fibrous capsule. This means that it's very unlikely to tear or rupture and start thrombosis. The second finding in a stable plaque is that it has very little inflammation. Remember, inflammatory cells carry with them all of those dreaded ACEs, hyaluronidase, protease, nucleases. And so when you have a lot of inflammation, they weaken the wall because they damage the extracellular matrix faster than it can be replaced. And the last finding of a stable plaque is that it really doesn't have any necrosis. And this probably reflects a little inflammation because the necrosis comes from degeneration of the processes which include inflammation. So when we talk about a stable plaque and its characteristics of thick fibrous capsule, little inflammation, and little necrosis, it is not prone to thrombosis. It's going to be associated with stable angina. It's a very stable physical situation that's going to obey the laws of Possel's law of R to the fourth, and so clinically this is going to be associated at the 70% occlusion level with a demand ischemia, and at the 90% level is going to be continuous ischemia or ischemia at rest. And that's very different than when we think of the pathology of our unstable plaque. We're back to the same discussion of forming an atheroma, but now we can see that an unstable plaque has a totally different pathology and therefore clinical expression. The first thing to remember is that it has a thin fibrous capsule. It has abundant inflammation, and it has evidence of necrosis. We can see right away that this is now going to be a disease of physical occlusion. This is going to be a disease of thrombosis and rupture. Because it has a thin fibrous cap, it is very prone to tearing. And when it tears, that's going to expose the collagen and the von Willebrand's factor to platelet aggregation. And that platelet aggregation is then going to make a stable plaque, and we've right away gone to thrombosis. Inflammation weakens, it has all of those inflammatory lysosomal destructive products, and the necrosis also provides a physical area of weakness. This area of weakness here is very prone to rupture and therefore intraplaque hemorrhage. We can see now unstable plaque has a very different clinical expectation than a stable plaque. A stable plaque has no clinical significance until it has a 70% occlusion when it creates pain with exercise, and at 90% there's pain all the time. But an unstable plaque can be significant at any thickness. It can be at 20% and still pose a great risk to your patient. The pathology now is not going to be a demand or rest ischemia, it's going to be the sudden onset of occlusion secondary to thrombosis or rupture. The pain is not related to exercise, the pain is unrelated to exercise and rest. This is not now going to be a stable angina, this is going to be an acute coronary syndrome. An acute coronary syndrome is defined by sudden onset of thrombosis and hemorrhage. Let's conclude this pathophysiology just with some important clinical lessons. The first of all is when we're talking about the differential diagnosis of chest pain, and that's its own separate discussion, but there are multiple organs that can do it: chest wall, pleura, pericardium, esophagus, and aorta. It's going to be myocardial when we can measure ischemia on the EKG. The second point is the differential of chest pain from ischemia, which is going to be angina, is going to be clinically discussed in two different ways. A stable angina, if it is related to rest and exercise. And we can specifically see what the pathology has to be. It has to be a stable plaque with a thick fibrous capsule, very little inflammation, and no necrosis. That's going to be very different from our acute coronary syndrome, which is unrelated to rest and exercise. And this is now going to be an unstable plaque with thrombosis. And then the last point we want to make is coronary artery disease is actually atherosclerosis. And atherosclerosis is not a disease of the heart, it is systemic. Atherosclerosis can be found in the aorta and the large muscular arteries. So anytime a patient has coronary artery disease, you have to go evaluate the rest of the body. The classic places we're going to see it are going to be in the abdominal aorta. So you should definitely screen your patients for abdominal aortic aneurysm. And then the other 3 arteries are going to be in our carotid arteries, renal arteries, and in our iliofemoral arteries. That brings us to the end of this discussion. Our next topic is going to be the epidemiology and stable angina of myocardial ischemia.